So welcome to this morning ESO TV session. We have an exciting topic about large cohort trials and the discussion of the results. And we have two exciting guests with us. So we have Dr. Götz Thomalla from Hamburg and Dr. Hege Aamodt from Oslo, who will be glad to discuss this topic with us today.
Thank you very much. My name is Bastian Cheng. Anke Wouters is my co-chair today. And maybe we can just start with the large cohort trials. That is another trial that actually changed clinical practice for patients with very large infarcts. There's just recently been a systematic review and meta-analysis published in Neurology showing that basically everyone profits from thrombectomy with large ischemic cores. And maybe we're today here to discuss, are there still any questions left? So for clinicians, do we now do thrombectomy on everyone, or are there maybe still gray areas that we should still look into, or are all questions solved? What are your opinions on this?
Yeah, so we still have to be clinicians, and if it's an extreme comorbidity and so on, we don't choose to do the thrombectomy, but it's very convincing with the results of the trials and the EPD meta-analysis showing really good effect on extreme large volumes. But for the aspect 0 to 2, it's still not so many people included in the large randomized control trials.
I'm asking because I think from clinical routine, I'm not sure how this is on your hospitals. People like in the field are maybe still struggling if there is an 80-year-old lady that comes in with aspects 1, maybe in the time window, but in our experience, there has been still some struggle if this is really the ideal candidate to perform thrombectomy. So that's, yeah. Do you have any view on this?
Yeah, I agree with I think the general feeling, if we see a CT with a huge infarct, that this patient still might benefit from thrombectomy. This is, I think, has not yet arrived in everybody. And I remember when we started the tension study, for example, we were not certain that this would be a positive trial. And I guess everybody was a bit surprised how clear this treatment benefit of thrombectomy in all the subgroups is. And we're still sort of digesting this and trying to find a way how to translate this into clinical practice.
Yeah, because do you consider the prognosis? Because of course these patients, in the end, there are a lot of patients who will not do good, who will have an MRS of 5 to 6. So do you consider like other things like age or when treating, and do you talk to the patients before you treat them? Yeah, of course, but...
Yeah, I think that's, as Anna said before, that's very important.
Yeah.
I mean, we do not treat the CT alone, and we have to consider the overall condition of the patient. And we also see that in virtually all of these trials, almost half of the patients are dying.
Yeah.
So, of course, the mortality is less lower in the thrombectomy group, but still this is a very severe condition, and so we need to find a way how to decide in which patients it's really helpful to go for thrombectomy. And age, comorbidities, these are the things we need to consider.
Yes.
And it's not only about aspects.
No, indeed. And did the results, when they came out, surprise you pathophysiologically? Because indeed we always had about the core and the penumbra and this concept, and then suddenly these trials were positive with a tremendous amount of infarcted tissue. Could you explain, or what are your thoughts about that?
Yeah, as I said, in a way, I think it was a bit surprising, but on the other hand, these are all large vessel occlusion patients. And I guess no matter how big the infarct is, there usually is some penumbra. And most of these trials also use perfusion CT, and so you could measure mismatch in penumbra, and there was mismatch in most of these cases. In tension, we didn't look into this, but I assume if an aspect is like 3 or 4 and there's a M1 occlusion, there will be some penumbra, and this may have contributed to the benefit.
Yes.
I'm not sure that that's all, but...
Yes, and in line with that, do you think no mismatch patients should we treat, or should we use perfusion imaging, or you think, or don't we use it? Yeah.
Well, taking the trials, I think we can make it simple. We don't need perfusion to guide these questions, because in tension, we by purpose made it simple. We just used the plain non-contrast CT and the CT angiography, and the trial was as positive as the others. It even showed a benefit in mortality. So I don't think we need perfusion CT, but if you do it and there is really a huge infarct and no mismatch, then at least, it feels like it may not be effective, but the trial data do not really support this at the moment. But there were very small numbers of no mismatch patients in the trials anyway. So maybe this is one of the areas of uncertainty that you mentioned before.
Yes.
Yeah. And some of the centers did the MRI before the thrombectomy in really large core infarct. So that was really a lesson learned from tension, that it was not necessary to do MRI in centers that did it. So it's the people are getting the treatment faster, and that is extremely important.
Yeah.
And maybe it's also worth mentioning that we are, of course, used to very, very good outcomes in thrombectomy trials. And before interpreting the results, look at that these patients are actually fundamentally different. And being able to walk or being not able to walk might actually make maybe a more difference than we saw in the first trials, where it's basically excellent versus non-excellent outcomes. So. But regarding the tissue composition, so we heard yesterday, for example, that maybe the degree or the extent of hypodensity may play a role. Is that an interesting area to look into it? So we see a plain CT, it looks kind of dark, but not very dark. Do you think there is data to say that, you know, the darker it looks, the more serious the ischemia is, or is that maybe some way to go forward?
Yeah, and that we see from some of the studies now, that it's quite much reversibility. Like we have all the MRI images, and we see irreversibility in all regions. So it's not everything that you see on the images is
lost completely.
No. So that is a new knowledge that we get now.
Yeah, so we might need more imaging tools or something to quantify indeed the degree and to know which tissue would reverse or what is indeed completely lost.
And not just the volume, but also the regions. So we need to be able to assess this more detailed in acute phase to select better based on imaging, but still we are clinicians and we decide it based on the clinical status, and people are coming quicker and family are there quicker. So sometimes you get the information that my mother, she didn't want you to something to happen now, just let it go, and then we stop, or there are severe medical conditions that also we stop. So you get always help from the clinical assessment.
Yeah, I think this is one of the crucial messages. But the other one, as you mentioned, so aspects is just it's helpful. It's helped standardize the evaluation of CTs, but it only looks at the distribution and in a way the size, but it does completely disregard hyperdensity, for example. And we had this nice debate yesterday, the pro-con debate, where it was about the question, should we treat all thrombectomy patients? And Greg Albers nicely brought up the different potential ways to look at imaging beyond aspects that may carry further information. And of course, I think hyperdensity or the net water uptake, which you can use to quantify this, may help, because there seems to be a clear, also consistent trend across different trials that if there's a very severe hyperdensity, so if the tissue is really dark, then these might be patients who do not benefit with lower aspects. And I think we still need more understanding of this.
Of really the tissue property that is captured by imaging markers, yeah.
And if you say we need more understanding, do you think we need more trials or sub-analysis, or how do we take this to the practice of patients, like the very large core, the very hypodense tissue? What should we do with it?
Well, I think it will be difficult to have a trial where we look at the low versus high net water uptake patients with a large core, so this will be very specific. I think this is the sort of understanding that you get from the data from the big trials in secondary analysis then. So we've started this with analysis of tension, and there's been a nice complementary analysis from the SELECT-2 study, which points toward the same direction. Now pooling all this data and having a data set of more than 1,000 patients, I think this will enable a better understanding with also power to look at treatment benefits or lack of benefits in subgroups.
Yeah, this might learn us more, and also when all the imaging is like analyzed in a uniform way, I think like perfusion and also the hypodensity, we might learn more in the future about this effect. Yeah, okay.
So this is obviously about thrombectomy, and treatment with thrombolysis and thrombectomy, kind of the pathways got kind of separated along the way. How to select patients, and maybe there are people that say, okay, large core trials, why not just do thrombolysis therapy on all of them? Would you do that? Would you thrombolyze a patient with an aspects of 4, or would you still say no? Or what's your take on that?
Yeah, to remove the thrombolytic therapy in advance, it's not so easy, and many places it's also always also the distance. So in my country, with so large distances, we need to use the thrombolytic therapy, and they are more eager to use it also at larger infarct course, and it helps. And sometimes the patients are arriving and it completely much better, and then we can skip the thrombectomy.
And also when a patient directly presents to your center, you still would give it in a very large core?
Then it's easier to just go directly to thrombectomy, and then
if you can do the thrombectomy very fast, then it's a reason to skip it. But indeed, for transfer patients, you think indeed it would benefit those patients. Yeah.
Yeah, I think that's an interesting question, and again, there was one pro-con debate yesterday where Pujakatri, for example, showed a nice view back on the historical thrombolysis trials, where first of all there was no exclusion of large infarcts, and secondary in the ECIS trials we had this signal of higher hemorrhage rates. But in general, and in this 1/3 MCA territory, the rule that we somehow learned that these patients might not qualify for thrombolysis, this actually comes close to a large core if you think of the size of the MCA territory. And in general, looking at these CT-based trial data, there is no real evidence supporting the exclusion of these patients. But these are all patients treated within 3 or 4.5 hours. So I think it's completely different if you're in the later unknown time window.
And it's an eyeballing rule anyway, isn't it? So it's, I mean,
still.
I'm not sure if you measure the volume of hypodensity on CT, I don't think that's very usual, and it's an eyeballing thing anyway.
But I think it should be also a clear message that if you are within the known time window of, let's say, 4.5 hours, there's actually no reason to withhold thrombolysis, even if the infarct is rather large.
And can you comment on how this was in the tension trial? I mean, were people receiving thrombolytic therapy? Did that modify the outcome in any way?
Yes, so there was about 1/3 of the patients had thrombolysis before, and there was no signal of more higher hemorrhage rates in these patients. It was also not a significant treatment effect modifier. But we have to be careful because there may have been some, so we didn't really look into the data yet, there may have been some transfer patients who received thrombolysis when the infarct was not yet a large core. And then when thrombolysis was not successful, they came to the interventional hospital and then they had a large core. So there's a bit uncertainty in the data. But again, what we have from data is more supportive. So there's no sign, at least, no alarming sign.
No danger signal.
Exactly.
That you should definitely not do that. That's not the case.
And that's the same in the other trials also.
And it brings us also a bit to the time, like the later window. I think there might be more uncertainty because not every trial included patients up to 24 hours. So what do you think about this time window of 12 to 24 hours? So you say, okay, be careful with thrombolysis, but also the results, should we interpret it different in this time window?
Yeah, so then we don't have so much evidence, and with so large core infarcts for standing for a very long time, often the patients, the general assessment of the patient makes you decide to not do the thrombectomy, but still sometimes they have very good collaterals, and it has not happened so much in the last hours, it looked like, and then you move forward. But of course, we know that the data are best for the shorter time window than 12 hours. So a bit more uncertainty, but still it seems reasonable to do the thrombectomy up to 24 hours in many of those cases also.
So you think indeed collaterals still play a role, and they indeed also with this large core, maybe collateral assessment or
so what we saw within 12 hours time window, that both good and bad collaterals, both groups really have an effect of thrombectomy. But what happens after many hours, collaterals also means something. So it's an assessment of different
different things you have to consider, I think, as well. Okay.
I think it's not a yes or no or black and white decision, and that's what we see. So the bigger the infarct, so the darker the tissue, the later the time window, the older the patient. So then you tend to feel less certain with thrombectomy. That's what I guess. So we all can create these cases like after 22 hours, 80 years old, aspect 0. Well, then none of us would be happy with thrombectomy. But I think, for example, for the 3 to 5 aspects patients, now we are very certain that there's a benefit.
Yeah.
For 0 to 2, the data is less clear. It was mainly the last trial, and they didn't have the late time window. So the uncertainties areas are still.
And also maybe MR versus CT, scoring of aspects, I also think it makes a difference.
Yes, you're right. So you tend to see larger lesions on MRI, but that's what I found really surprising also in the last trial. They used MRI, but they really have very large lesions. So I mean, just looking at the numbers, it's crazy. And even these patients with a 200 ml stroke at the beginning can still benefit from thrombectomy. And this is really a new lesson learned from this trial, I think.
And traditionally, we would say maybe that right hemispheric stroke would maybe recover better than left hemispheric stroke. But as I know from the tension data, at least there was no signal that right hemispheric large core trials differed in any way from the left hemispheric. And it would be, of course, interesting to pull all these trials together and see which kind of eloquent areas we actually saved in large core trials. Since clearly volume is not always eloquence.
Yeah, so it's great that the data from the different trials now are being shared and that we also can share data from more cohort studies and put together and analyze this data more based on what we already have got of information from the patients. I think that's important to focus on now and not to start.
So there are plans to bring individual data together and to bring imaging together from all the large core trials. So it would be very helpful.
Interesting. And also, do you do some follow-up of this patient, of the tension trial patient, like a longer follow-up? So, because I think maybe patients' reported outcome measures or also of the caregivers might be important. How do they feel if they look back? Are they happy that their relative was treated, or do they say, no, I would never want it again? It might be interesting to see.
Yes, so in tension we looked at patient-reported outcomes. So we asked them for quality of life, of course the survivors, and there were 50% mortality. And we did this also after 1 year. So we don't follow them longer, but the 1 year follow-up was actually quite interesting. It was very consistent. So we did see a consistent treatment benefit, even some patients who further improved from 3 months to 1 year, which I think is a specific factor for the large strokes, because usually we see with the smaller strokes improvement, the greatest improvements are within the first weeks, but the large strokes may have some longer time window for improvement also. So I think that was reassuring or encouraging, and asking the patients about their quality of life confirmed the treatment benefit. There was a clear difference. We didn't ask, would you have liked the treatment? The typical question from the craniectomy trials, where you sometimes ask the patient, are you happy with the decision? Most patients said yes. In these trials, we didn't ask that.
So maybe with the last minutes we have, maybe we can bring really to clinical practice and say that how has it changed the workflow in your hospitals? What do you do now that you have been done differently before?
Yeah, so I was in a center with a lot of MRIs because of the long distance, and they were unsure if it was really still possible to do it. So that has been very, very much reduced. And then the thrombectomy is done faster, and the people are not so much more conservative now, so we really can transport people with really large core infarcts, and sometimes it's too late, it's not possible, it's not done even though they were sent to our center, but we are now change our mind. When the evidence came and we were more liberal, the mortality rates increased and people were a bit concerned. But after the large core infarct results, people are have understood that now this we really should expect a high mortality rate. It's a correct way of doing it. So people are much liberal and faster, and that is extremely important.
Yeah. Okay. Great.
Great.
So, yes. I think we learned a lot
There's
today.
still a lot to learn.
There's still a lot to learn. We learned a lot, but there is still a lot.
The more you dive into it, the more you actually find that there are still many questions.
there are still many.
I think it's important to say it kind of had immediate impact on the clinical practice. So that's I think really reassuring after all this effort of doing these trials. So.
Yeah, after all these thrombectomy trials from the future, that now we treat so many patients, and so many patients are benefiting from
that's
treatment.
Reassuring.
Yes. Indeed.
Thank you very much for being our guest today. Thank you, Anke, for co-hosting this.
Yes, you too. The same. Thank
you.
you.
We wish you all a nice conference and enjoy day 3 or 2.5.
Yes.